All right, so good afternoon, everyone. On behalf of the President's Anti-Racism Task Force, I'd like to thank you all for being with us today, and a big welcome to our Sunnybrook staff and to our extended North Toronto, Ontario Health team, and a happy Black History Month to all. My name is Christopher Townsend. I am the Manager of Organizational Development and Leadership and also co-chair for the President's Anti-Racism Task Force. Today's conversation is the first in a series of addressing racism, decolonization, health equity, and allyship within the Black, Indigenous, and other racialized communities. We're joined virtually today by a panel of experts aimed at answering the many questions surrounding COVID-19, the disproportionate impact on Black communities in Ontario, and vaccine confidence. The theme of today's conversation: impacts and implications for Black communities in Ontario. Before we get started, we acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse nations, Inuit and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We are all treaty people. Many of us have come here as settlers, immigrants, newcomers in this generation or generations past. I'd like to also acknowledge and honor those who came here involuntarily, particularly those who are descended from those brought here through enslavement. At this time, I'd like to introduce the panel. And if you could introduce yourself by your first name, the department that you work in or organization, and just for efficiency and ease, I will cue you in. So first we have Dr. Abdurrahman.
Hi, everybody. I'm Zainab Abdurrahman. I'm an allergist and clinical immunologist. I actually don't work at Sunnybrook, but I am affiliated with McMaster Children's Hospital. So I'm affiliated with Hamilton and the McMaster Group, and I also work primarily in the community in Mississauga at Q&A Allergy.
Thank you. Next, we have Dr. Auguste.
Hi, I'm Born Auguste, a nephrologist here at Sunnybrook Health Sciences Centre in the Department of Medicine. I'm happy to be part of this discussion today, and thank you for inviting me.
Next, we have Camila Clayton.
Hi, my name is Camila Clayton. I'm a PAA at Sunnybrook. I also have private practice in social work and psychotherapy. I work in general medicine in the hospital at Sunnybrook.
Thank you. And Dr. Dixon, is she here?
Yes, she is.
All right.
Hi. Hi, I'm Marjorie Dixon. I born and bred at Sunnybrook. I actually did a rotating internship there. I'm an OBGYN and a reproductive endocrinologist and medical director at Innova Fertility. So thank you for having me.
Thank you. Leon Latty.
Hi, my name is Leon Laddie. I'm a physiotherapist on B4 in the stroke unit.
Thank you. Dr. Murray Norris.
Hi, I'm Mihai Norris. I'm a specialist in internal medicine and specialized geriatrics. I work at Sunnybrook, and I'm the faculty lead for Black and Indigenous resident application and mentorship at the University of Toronto. Thank you for having me.
Thank you. Next, we have Dr. Dominic Shelton.
Hi, I'm Dominic Shelton, an emergency physician here at Sunnybrook, and I'm the medical quality and safety lead in the emergency department.
Thank you. And next, we have Alicia Stewart.
Hi, everyone. I'm Alicia Stewart. I'm a patient care manager in the nephrology program, and I'm also a co-chair of the President's Anti-Racism Task Force. I'm happy to be here.
Thank you all. A bit of housekeeping before we get started. If you do have a question, please place them in the chat feature and we will do our best to address them at the appropriate time. Thank you to our panel of experts. And at this time, I'd like to hand over to Dr. Dominic Shelton, who will begin the conversation.
Thank you, Christopher. So, you know, we have a very serious and life-threatening paradox that exists within the Black community that really spreads across North America. That paradox being that we've been inflicted with the COVID infection at disproportionately high rates, and yet we are more likely to refuse or have concern about the COVID vaccine. So let me emphasize those points with some numbers. We make up 9% of the population in Toronto, but 26% of COVID cases. I don't know about you, but I certainly have been personally affected. I've lost 3 extended family members to COVID to date. Another important stat to pay attention to is that of all people that are hesitant to take the vaccine in Canada, 30% are Black. This hesitancy of vaccine amongst Blacks is not unique to COVID. Black people have lower rates of receiving the flu shot compared to the general population, despite being hospitalized at a disproportionately higher rate. So what's the reason for this refusal to accept some of these potentially life-saving vaccines of modern medicine? Well, the explanation is deeply rooted in institutionalized racism that exists within our society. Historically, a Black life has not been valued the same as a white life, and therefore the health of Black people has not been addressed the same as that of whites. There is well-documented proof of this in the history books. For example, the Tuskegee study was conducted by the US Public Health Service beginning in 1932 and involved Black men who were misled to believe that they were receiving free healthcare. But instead, they were actually participating in a study without their knowledge or consent on the effects of untreated syphilis. So as a result of this, dozens of Black men died and infected their wives. The study actually was only stopped in 1972 after the media disclosed it. So this disparity in the value placed upon white versus Black lives is built into the healthcare system and plays itself out on a daily basis with our interactions with the system. So whether it be a difference in pain control, in thinking that we're more tolerant of pain and assuming that we may even be drug seeking, or treating us actually with some level of disrespect or being dismissed, or a doctor ordering fewer tests on a Black person or not being referred to a specialist. These are all ways in which medical racism, as I call it, is played out on a daily basis for Black people when they interact with the healthcare system. This is what leads to the mistrust in healthcare. It's one of the major reasons why Black folks don't embrace medical treatments when recommended, despite being the best advice. Now, you may have some specific concerns and questions about the vaccine, which we hope to address today. But we wanted to start by acknowledging that your possible lack of confidence in the vaccine may be deeply rooted in your past experiences or that of people that you know due to medical racism. We couldn't talk about vaccine hesitancy amongst Blacks without addressing this elephant in the room. So as Black healthcare providers at Sunnybrook, we wanted to use this opportunity to step out of our silos and be visible to you, and to lend our support to keeping you healthy, to inform you about the vaccine, and to give credibility to the science that has developed the vaccine and encourage you to get it when your opportunity arises. So with those opening comments, I would now like to engage my fellow panelists by beginning with a series of questions, some of which were pre-submitted, so thank you, by the audience members today. So let me start off with the first question, which I'm directing towards Dr. Auguste. What are some factors that lead to COVID-19 affecting Black communities more than other communities?
Thank you for that question, and thank you for the introduction. I think it's important to dissect this in multiple layers. There's no quick answer or simple answer for this. It goes back to important things we need to discuss, ranging from the social determinants of health, which have disproportionately affected Black communities, ranging back from the fact that the Canadian Medical Association has pointed out about 85% of risk-related infections due to COVID-19 are related to some social determinants of health. By this social determinants of health, I mean people from Black populations and Black communities would tend to have more likely to be in poverty, poor housing, and situations that do not allow them to, one, engage in significant social distancing mechanisms, and also to not have the opportunity to take time off from work. As we pointed out, as some of the data has shown, nearly about a third of patients who are part of the essential workforce in the healthcare field, as well as the supply chain field, are from Black communities and other racialized communities. And this affords them the opportunity to actually, it presents the opportunity for increased risk of infection in these populations. Secondly, as you alluded to in your introduction, there is a significant distrust of the healthcare system, ranging back from the Tuskegee experiments and many other factors as well. Black communities and individuals from Black communities tend to mistrust the healthcare system for a variety of reasons. And I think sometimes we do disservice by vilifying individuals by their lack of trust for the to the system. And that trust is validated just given the historical context. What do I mean by that? In instances where people don't seek out healthcare and follow up with important interventions as it relates to seeing if they have any history of diabetes, hypertension, and just general checkups within the medical system. As we know, some of these conditions and these comorbid conditions have increased the burden of comorbidity related to COVID-19. So there are multiple layers there, ranging from the social determinants that I mentioned, as well as a lack of mistrust, lack of trust for the system. So these things are intertwined, and as a result, lead to the higher prevalence of COVID-19 infections in the Black community.
Okay, thank you for that very comprehensive response, Dr. Oghis. So next question is directed to Dr. Abdurrahman. How does the COVID-19 vaccine work inside the body?
Okay, so similar to any other vaccines, essentially what happens with the COVID-19 vaccine is that you are given a little piece of mRNA, which tells your cells to basically build a small piece of the virus, not the entire virus, just the little part called the spike protein, which is actually what gives the name of corona to this kind of group of viruses. So then your body will see this little tiny piece, and then essentially it'll get broken down and presented to your various immune cells, and then they're going to start to mount a response to it. So unfortunately, your body thinks it's going through an infection, even though it's not getting infected. So you will see some of the things you associate with infection. So a bit of sometimes elevated temperature, soreness, redness. These are all things your body does when it's fighting an infection. So your immune system sees it and it gets excited. It starts doing things to help hopefully reduce infection. And then little pieces of that spike protein will be broken down so that your the second part of your immune system, the adaptive part, will see it and start to make antibodies to it. Specifically, they'll make antibodies that are called memory antibodies, so they can be called upon when you are truly infected and fight off the infection to hopefully prevent you from being infected. So this is kind of the steps that goes through. So similar, other vaccines are similar in terms of either providing you with the little pieces of a different kind of virus or a bacteria, and then basically giving you these little nubbins to your immune system. It sees it, chops it up, and actually prepares a whole army ready to attack if you are then exposed with the real virus, but without giving you the virus, so you don't suffer the effects of the illness, but you mount a robust immune response to it.
Thank you. And a follow-up question to that, and I know you just touched on it, Dr. Abdurrahman, is that, but someone specifically asked, can the vaccine give you the actual COVID infection?
Absolutely not. So the vaccine only gives you the ability to make a small, tiny part of the virus. So it's just making the spike protein. The virus actually has a lot more pieces. So you actually cannot build and make up a whole virus. You don't have all the other parts. You don't have all the other kind of enzymes it comes with. So you cannot actually get infected by this vaccine. So it's almost like, if I gave you the pinky, let's say like a pinky finger, that's all you have. You cannot recreate the whole hand in your body, which could then cause troubles. You only have a tiny part of it, so it cannot infect you.
Okay, thank you for dispelling that myth. Dr. Dixon, should pregnant people get the vaccine?
Sorry, I hadn't unmuted me. So that's a good question, and we get it a lot, particularly from the perspective of so many women not knowing. And the reason why currently there's not a blanket recommendation, because if you know in pregnancy, often we consider women to be relatively immune compromised and at risk. And that's why sometimes the women line up first. The people who are most at risk are the elderly, the pregnant, and infants who don't have that immunity. But when it comes to COVID-19, the coronavirus vaccine, we actually don't know if pregnant women should or should not, by virtue of the fact that we don't have the information from the clinical trials, because the trials that looked at the safety of this vaccine in populations excluded pregnant women from study. And therefore, it's not that we believe that there's any inherent risk in receiving the vaccine. The main issue is that we just don't have the information. So we can't endorse a blanket, all pregnant women should be vaccinated with coronavirus. But that said, we know that the worldwide data actually shows that 8 to 11% of pregnant women will require medical attention for coronavirus, and they are at greater risk of requiring an intubation, so needing ventilation support, than aged match cohorts. So other people who are not, individuals who are not pregnant, are less likely to, once they get coronavirus, to need to be ventilated. So there is a relative increased risk to women in pregnancy. All that said, the answer to the question is, if you are at increased risk of other morbidity in pregnancy, such as being obese, being hypertensive, having diabetes, having other respiratory comorbidities, it needs to be discussed with your healthcare provider and considered on a case-by-case basis, because the lack of knowledge sometimes is superseded by your risk of not having vaccine if you do get sick in pregnancy. So much as we don't have the definitive information to say that everybody should be, if you are at risk, you work in an ICU, you're intubating patients, you're a frontline worker, and you're pregnant, we should not be denying you vaccine if your risk of illness, if you do get coronavirus, is worse than what we know about the vaccination. So discuss with your healthcare provider if you are pregnant and you are in those risk categories, and have an open discussion with your pregnancy care provider, because you are not excluded from eligibility for the vaccination if you are pregnant. I hope that was clear.
Yes, very clear. The question was asked, why do more Black people die of COVID-19? And I'll take this question. So I think the answer to this really is embedded in the response that Dr. Auguste provided, that it's really what are the elements and factors that lead to more Black people acquiring the infection. And because we have a disproportionate number of Blacks that have been infected with COVID-19, therefore a disproportionate number of Blacks relative to the population are actually dying from the COVID-19. So it's not that, so of all people who have the COVID infection, Black people are not disproportionately dying relative to all other people that are infected. It's just relative to the general population of those who are infected, not infected, that were just being infected more, and therefore, you know, that is manifesting itself in mortality. All right, so the next question is directed toward Dr. Norris. Will the vaccine still work if my second dose is outside of the 21 days?
Thank you for that question. And as an internist, geriatrician, I just wanted to add that, you know, with the delayed access, the deferred access to healthcare, we have a Black population whose chronic health might not be as good, and higher prevalence of diabetes and hypertension, and those comorbidities might also contribute to the increased mortality associated with COVID. Now, with regard to the question about how the delay is going to affect, what we know is that the Pfizer vaccine in the trial was tested. The second dose was at 21 days, with Moderna at 28 days. But we also know that after the first dose, there was 50 to 70% effectiveness in preventing severe COVID, but that effectiveness actually was higher after the 10th day. So given that there's a scarcity of vaccine worldwide, a decision was made that if we, for the greater good, we should offer as many first doses as possible. And in the UK, they have tested giving a second dose at 6 weeks and at 12 weeks. And so that has been done. Now, there are other vaccines where there's a repeat vaccine given a year later. So because there's this notion of vaccine memory, such that there is a rationale for delaying a second dose. The challenge is that in the trial, in the manual, it was at 21 days for Pfizer and 28 days for Moderna. So, you know, there are other instances also in medicine where we do off-label use of medication. And given this is an emergency, it is reasonable to do, and we expect that the second dose will be within the frame of time where it will be beneficial still. And if Dr. Abdurrahman wants to chime in as the expert.
Yeah, I think that's a comprehensive answer. Thank you. The next question is directed to Mr. Latty. Someone asked the question and made the statement and asked the question, my friends and family are sharing what I think is vaccine and COVID misinformation online. What can I do about it? Or should I even try to intervene?
Yeah, that's a great question. And I get misinformation and like random WhatsApps from my family all the time because I'm like the medical person in the family. And I'm sure that's similar for many of you guys. The first thing I would say is definitely just you want to be a resource. So do like this is actually this forum is a great tool to be used as a resource. It's going to be recorded. Kind of it's something that you could forward if you do see misinformation and somebody from your family sends you something, like you can forward this link because it's from trusted clinicians, from other resources who are Black and who kind of look similar to your family, for instance. And you can send it to them and you can be like, hey, I saw that you sent this article on Facebook or WhatsApp, what have you, about the virus or the vaccine. And here's some really good information from doctors where I work or doctors who I know that can kind of help dispel some of the myths. So to answer like, if you should intervene, I would say yes, definitely, but you know your family best, right? So how you go about doing it or the time, whether it's like a direct message or it's a text message or even a phone call, because some people respond best to that. I think that's the best thing to do, right? Because it's all about education, right? That's kind of why we're here, to provide education to others. And I think long term, like that helps with building critical thinking skills and how to actually check the sources on the information you're getting. And that gives you kind of more, it empowers you to talk to your family and it helps them to talk to other people as well, because they have these good resources, kind of like this forum.
All right, thank you. So, you know, there's been a lot of talk and skepticism around how expedited and how quickly this vaccine came to be. Dr. O'Geith, could you speak to this concern that a lot of people have in terms of how did the vaccine get made and approved so quickly?
Yeah, that's an excellent question, and I think part of that has also generated a high degree of skepticism around the how quickly the vaccine was created. So I think that's an important question to answer. So this question can be answered in two parts. I think part of it is related to the new mRNA technology in terms of how the vaccines have developed, which deviate from the traditional methods which have been used to generate vaccines in the past. That aside, but I think the biggest factor has been the collaboration with multiple scientists, experts around the world. This was a study that was, in terms of the research, 10 times more funding and involvement compared to traditional vaccine researches that was done in the past. So there was significant collaboration to allow for that, significant human resources, the volunteer work, everything was immense. Sometimes I use the analogy, not a slight at the construction that occurs at Yonge and Eglinton, but you could imagine if you have all the construction workers around the world coming in to help assist with the construction there, things would probably move along a lot faster. So if you have all the collaboration around the world, the money, the resources, that's part of the reason why the vaccine was created that quickly. I think there was just one priority, one task to do, and was to create a vaccine. And all of energy was actually focused in that sense to develop the vaccine. So I think these two factors accounted for the reason why it was developed so quickly.
Okay, thank you. Dr. Norris, if Black communities are more affected by the COVID-19 virus, shouldn't they get prioritized access to the vaccine? And so someone asked, how is that working? When will the vaccine actually be rolled out to the public? So I think there's sort of two components to that is, you know, disproportionate infection amongst Blacks. Why not? Why isn't this reflected in the vaccine rollout? And then I think just in general, are you able to share any information about the vaccine rollout to the general public?
Thank you. And that is an important question. As you know, in Canada, and it was also in France, there is a lack of data around race and healthcare upon Black race, such that the notion of collecting race data around COVID has been only recent. Actually, there was reticence about gathering this data, and just, you know, the Dalalana School of Public Health at University of Toronto has a special fund, Black Lives Matter, to support research tracking COVID and Black people and COVID and the vaccine among Black people. So the data is lacking. I think right now the emphasis has been on the elderly and in hospital. And while Black people in Toronto make 9% of the population, Black people are disproportionately represented in the healthcare force, around about 22%. So we're really encouraging, especially people who are on the front line, to embrace the vaccine. As you know, there's been delay in the rollout in the community, and there is built-in inequity in our healthcare, such that richer neighborhoods have more access to better hospital care and more access to family doctors. So this is, I think, as a community, we'll have to be more proactive. That being said, there are community health centers that focus on Black health. One is known as Table, and I would encourage Black folks to really advocate to access the vaccine when it is rolled out in the community.
All right, thank you. Another myth I'm going to ask Dr. O'Geith to dispel, and that is the question was asked, I've heard that the baseball great Hank Aaron might have died from the vaccine. Is that true, or is it even possible?
Again, that's a very good question. I think for those who don't know who Hank Aaron was, he was a baseball Hall of Famer who recently passed away at 86 years old in Atlanta, Georgia. He publicly got the Moderna vaccine on January 5th at Morehouse in Atlanta. And as an effort to make an appeal, as well as to show that he had confidence in the effectiveness of the vaccine and wanted to do so publicly and wanted to go out and do that. Unfortunately, he passed away on January 22nd at home. And that's stirred on a bunch of discussion on social media, namely with many people who've had a history of skepticism around vaccination, pushing the idea, saying that he died because of the vaccine. So this has been fact-checked by numerous reliable sources, including the Fulton County Medical Examiner. Dr. Sullivan came out and released a statement saying that Hank Aaron died from natural causes in his sleep. And there have been numerous discussions around this to indicate that he had no significant allergies after the vaccination, no history of any anaphylaxis that would account for complications related to the vaccine. So this has been fact-checked extensively by reliable sources, including the Fulton County Medical Examiner, to dispel that his death was related to the COVID-19 vaccine, and that was not the case.
All right, thank you again for dispelling another myth. A question to the panel. So who amongst panel members has received the vaccine, and did any of you have any hesitancy about receiving it?
Yes, I received the vaccine, and I did experience some hesitancy. And in looking back and reflecting, this hesitancy started from before the introduction of the vaccination, and that it was ready to go late last year. Of course, in our own communities and in our own circles, we have this conversation. And my opinion and perspective at that time was, oh, absolutely not. This is too new, the novelty of it. I don't know what this vaccine is going to do in my body. I will be on the sidelines watching to see how this works out for those who go before me. That's full disclosure, my honest answer about how I felt about it. And then when I heard that the vaccine is here and that the organization established the framework, the prioritization framework, initially, as a manager, I wouldn't have been prioritized, but on the revised framework, the area in which I work in was prioritized as group 2. And that made me think of it a little bit different. So here I am, and I have an opportunity to take it sooner than later. Am I going to take this opportunity? And so I thought about it. And during this time, I was still engaging with my staff who were already confident that they were going to take it. And I was undecided. And so I took some time to think about it, and really was over a weekend at home. And I realized I was feeling an uneasiness. And as I sifted through those emotions, what was left behind wasn't it wasn't so much the novelty of the vaccine, while that was an issue. It was also the historical context. And what is this going to do to me as a Black woman? Right? And I mean, I'm a registered nurse. I've been a nurse for 20 years. And clearly I'm very concerned about this pandemic and the impact on not only my community, but patients and staff. So what I had to do with this was really just reconcile it on my own and work it through on my own, given the evidence that has been provided. The organization provides a lot of information, also trusted colleagues who I've had conversations with helped me to make that decision. So so I came to the decision to do it. I received the first vaccine in January, and I have received my second date for February, and I will be moving through with the second vaccination. So yes, I did experience vaccine hesitancy, but it was very important that I work through it on my own, and that it was an informed choice. No one forced me, no one coerced me, no one implied that I had to take it. If that were the case, I am confident that it would have been a hard no. So it's really important to respect individuals' decisions and decision-making process, and allow them that space to make that decision.
Okay, thank you, Ms. Stewart, for your honesty and openness and talking about your hesitancy. And so just for a quick show of hands, again, amongst the panel members, in terms of who has received a vaccination, realizing that not everyone may have been called upon yet based on your role, but who has received.
Yeah, I
Okay.
can also echo exactly what Alicia was saying. I got the first and second dose. I was fortunate to get it. And I also had a ton of hesitancy before. But for me, like I was saying, I did a ton of reading, a ton of research before actually kind of even, because I knew this decision was coming at some point. And I got the second dose. And so far, so good. Things are great.
Okay, great. Thank you. Next question is for Dr. Dixon. So can the vaccine affect fertility?
Okay, so this is my opportunity to dispel a myth. So it doesn't. We just talked about social media and how things can get a life of their own. That is not science. That is science fiction. And how that happened was because the infertility population is very busy online, and that was a question. People didn't have the answer. And so somebody somewhere planted the seed that there is a protein that's essential for the placenta to stick to the uterus and for blood flow to develop and for a placenta to develop nicely that is affected by the vaccine, but it's not true. Not true at all. And, you know, everything has a little bit of truth. So there might be some amino acids in that sensation 1 protein that are similar to the spike protein, but no, vaccination does not impact your fertility. So fake news, dispelled.
Okay, thank you. Someone also asked a question about the vaccine, this mistrust, and then layered on top of that is the fact that there's these delays in receiving the vaccine, and asking why are there delays, and it makes them trust the vaccine even less. And so I'll address that by saying, unfortunately, that's one that is out of our control. And when I say our control, you know, our hospital, public health, even at a federal level. When you think about it, every country in the world is competing for this product of the vaccine. This is a supply and demand issue. It just cannot be supplied fast enough. And then when you layer on top of that the fact that there are certain regions, namely the European Union, that has imposed restrictions on the exporting of the vaccine because they want to make sure that their own countries are well supplied before dispersing it to the rest of the world. And then there have been production issues, right, on the local levels at the pharmaceutical companies, which have also been some major challenges. So I think it's important for these factors that are beyond our control to have any bearing on the confidence in the vaccine itself and the validity and the need for you to take it and for it to be beneficial to us. So that's a separate issue, but I realize that the delay in getting it isn't helping in terms of the perception. Next question is for Ms. Clayton. Someone asked a question, how do we reconcile the mistrust of Blacks towards the healthcare system and the present day advocacy to then make a decision about the vaccine?
So thank you for this question, and to all the panelists that have offered some context around this. I'm hoping that my answer will not be redundant. It'll just serve to kind of build out mistrust and understanding of mistrust a little bit more. And so what I'll say is that the Black community's mistrust of healthcare as a system is a result of a long history of violence against people of African descent. And from a medical perspective, beginning with non-consensual gynecological experiments on enslaved African women. And so the trauma associated with these violent experiences has been passed down through the generations. And what it looks like today is a collective feeling or understanding that systems are not made for Black people and that skepticism or mistrust are necessary for safety and survival. And so although we know that the type of abuses experienced by members of the Black community largely don't exist in the same way today, we do understand that systemic anti-Black racism is embedded in healthcare, and it affects everything from access to the system, treatment within the system, and of course, outcomes. And so the advocacy, or probably a more better word for it would be resistance, that we're seeing now is really about holding healthcare and other systems accountable for not providing equitable service to members of the Black community. And so mistrust from the Black community is definitely connected to vaccine hesitancy. And I'd also like to offer that the current efforts to increase the number of people taking the vaccine may feel less like genuine care for their health and well-being, and more about a sense of urgency to address an issue that also impacts all communities and not just people of African descent or members of the Black community. And so with that context in mind, when we think about what is needed to build trust with members of the Black community in medicine, we really need to be looking long-term in addition to the urgent need to address vaccine hesitancy. And so in the short term, there needs to be clear, consistent, and accessible information shared about the virus and vaccine, and this is the perfect forum for that to happen. And some of that information can include the development of the vaccine and Black participation in clinical trials, testimonials, which we've heard from Leon and Alicia today, around or from members of the Black community that have taken the vaccine from various backgrounds and social locations, and how they're doing, and some of the challenges or thought processes they went through before making the decision to receive it. There also needs to be transparency around the risks or side effects associated with the vaccine, with a focus on addressing a lot of the myths that exist out there. And someone on the panel also mentioned that we need to have compassion and understanding for members of the community that are still struggling to have trust in the system or the vaccine. And then in the long term, there needs to be an acknowledgement of the historical and contemporary presence, of anti-Blackness within the system, and the ways in which biases and assumptions about Black people contribute to disparate treatment. And I want to be very clear in saying that when I refer to healthcare, I'm not only talking about the clinical team, because everyone in the system has a role to play in ensuring equitable patient care experiences. And the very last point that I will make is that building trust requires a great deal of work in theory, but also in practice. So this isn't about reading a book, starting a book club, reading articles. We need to really get into some action-oriented movement in this area. And it also takes a commitment to health equity for members of the Black community. And this can only happen in an institution that is equally committed to equitable experiences for all members of staff. And as a member of the President's Anti-Racism Task Force, I can say that we are committed to playing a key role in ensuring that that vision for Sunnybrook becomes a reality, with the development of an action plan to address racism and create an inclusive anti-racist organization where staff can feel safe and proud to work, and patients can be assured that their holistic healthcare needs are met.
Thank you for that powerful response to an important question. So thanks again. Next question is directed to Ms. Stewart. So as a leader in the organization, how do you support staff in their hesitancy in taking the vaccine?
Thanks for the question, Dr. Shelton. I think that as a leader, you have to appreciate that this is a sensitive topic. And it's not only within the Black community, but clearly the panel here has explained reasons why it has greater meaning and more sensitive within the Black community. And given that fact, we have to be very open and approachable to have the conversation with staff, and be very mindful of your approach in the conversation. So instead of asking an employee or one of your direct reports if they're going to take the vaccine or if they want to have their name added to the list, I think the conversation should sound like, what are your thoughts about the vaccine? What information do you need? Do you have any questions or concerns? How can I help you get those answers that you need? Being aware of the opportunities for staff to engage in forums similar to this. Distributing the flyers and the communication so that staff can log into these forums. Encouraging staff to access the information that the organization has provided. Participating in the town halls or watching the videos after. just really supporting staff and acknowledging that this is very sensitive and that it is a personal choice, and also that they must make an informed choice. So how one makes an informed choice may differ from another. So as a leader, I think that it's important not to be coercive or in your communication implying that it is an expectation. I can tell you that that will not be effective. As a matter of fact, if somebody is already feeling sensitive or some hesitancy towards the vaccine, by taking that step, you're going to get some heels digging in, and you're not going to allow that individual to process their decision-making process independent of a feeling or experience of coercion or a forceful nature. So as a leader, you really need to lean into the experience. Get educated yourself. For those of you who are on this call, I've noticed some names. Thank you to my fellow PCM colleagues for logging in and participating in this, because this is information. This is how you're getting informed so that you can be a good support to your staff and being present and respecting their processing of a decision to receive the vaccine or not. Thank you.
All right, thank you very much. A question to Dr. Abdurrahman. Someone said, I've heard that people can develop allergies after taking the vaccine. Should I be concerned if I have allergies?
Okay, so vaccine allergy is very actually uncommon. Generally, we see vaccine allergy or anaphylaxis to vaccines happening about 1 in a million. With these vaccines, we've seen a slightly higher signal. That is, with the Pfizer vaccine, we've seen about 5 per million doses. And then with the Moderna, about 2.5 per million doses. These are still extremely rare. So you have to keep this in mind with, if you get COVID, the chances of you dying from COVID is about 3 per 100. So this is what we're always kind of balancing risks versus benefits. So with that, from an allergy standpoint, the only people that, we've kind of required to not proceed, at least in a routine fashion, would be someone who has an immediate onset reaction with their first dose of the vaccine. These patients should be assessed by an allergist first, and then decisions can be made about further dosing. And then the other would be if people are known to have an allergy to polyethylene glycol, which is found in common laxatives as well as many over-the-counter medications. The one thing I will say about PEG allergies is extremely rare, as in very few patients who have this, and they're well known to allergists because they really cannot easily shop at somewhere like Shoppers Drug Mart because many of the over-the-counter formulations of medications contain this. And so their lives are heavily affected by this, and they're often already identified. So if you have regular allergies, like something like food or penicillin allergy, this is not a contraindication for you having this allergy. It's important to know what's not in the vaccine. There are no foods, no peanut, milk, egg, or any foods in the vaccine, no gelatin in the vaccine. There are no venoms, so no like bee venom or wasp venom in the vaccine, nor is there any dyes. For any of those who are worried about something like mercury, there's no thimerosal or mercury components. There's no antibiotics in it. Some other vaccines have antibiotics to help keep them from having issues when they're being processed. About these 2 vaccines that we have currently in Canada do not have any antibiotics in them. So a common antibiotic allergy would not be a contraindication to getting the vaccine.
Okay, thank you for that. And so that's why after receiving the vaccination, people are asked to remain in the site where they had the vaccine. Usually the recommendation is about 15 minutes because most allergic reactions are going to occur early on. Some may be delayed even longer beyond that. But just to let you know that's the rationale as to why we get people to wait around for 15 minutes after the vaccination, and all sites are well prepared to deal with allergic reactions if in the rare event that they occur. So having said that, we also invited the opportunity for you to submit questions. I'm not sure if there are any that came through in the through this process in the chat. If not, there were some other questions that were submitted, but I'll turn it over to Mr. Townsend at this point for us to, for him to direct the questions.
No problem. Thank you, Dr. Shelton. So I do have a few questions, and I think this is a great follow-up question to Camila Clayton's answer. And it says, or it reads, I heard that the vaccine booking system will be online in Ontario. What do you think could be done to remove barriers like this, which might prevent people from being able to get the vaccine?
So I think we need to acknowledge that not everybody has access to the internet. And so finding ways of, creating accessibility around that is important. Also making sure that the information is available in different languages and in very sort of plain speak, so that people don't have to decipher what it is they are or are not consenting to. Those are two, I think, the major barriers that will present themselves for folks. I don't know if anybody else wants to chime in on other potential barriers.
Hi, actually, I will chime in for that. I think this is also a great opportunity for us to engage our community health centers, where many of our patients and our Black population are typically going there for advice. Yes, they may not have regular internet access, but that's a place where perhaps we can empower them to be able to sign them up and to make sure that they have access. So we really need to focus on community involvement when it comes to this rollout. We really can't expect it to just be something online for people to access. We have to go out to the people and engage them with healthcare professionals that they're comfortable with and are used to getting advice from. So I think that that part has to be addressed when we go into phase 2 and phase 3 rollouts of the vaccine. Community involvement is going to be essential to help deal with any inequities in terms of the delivery of the vaccine.
Okay, and this question is directed to Dr. Abdurrahman. It says, is there anything you really wish people knew about COVID or the vaccine?
So I guess I really wish people would realize that COVID has been disproportionately ravaging the Black population in terms of people not having access to things like paid sick leave or other opportunities for them to remove themselves or recuse themselves from potentially scary situations where they're close to other people. So we've had increased infections and we've had people disproportionately dying because of the disproportionate amount of infections. So this is real. This is affecting people. It's affecting people in your community. It's potentially affecting your family. So this is a time when, even though, there's some hesitation in terms of how fast this happened, this is one of the times that I think as the Black population, we have the opportunity to get this to our population, specifically to address the fact that it has disproportionately affected us. So I hope that people will listen to all that has been said to date on this conference, and also all the information that is available from trusted sources, that this is a safe vaccine, and us taking it is not an experiment, but it's actually an opportunity for our communities to be safe and for us to hopefully return to a lot of the things that we enjoy. Our community is rich, and people want to go back to religious gatherings, to family gatherings. I want to hug my mother, so this is that opportunity to do that. So I really hope that everyone takes the time to really think about this in terms of getting the vaccine.
Thank you. Lots of questions coming in. Another question here. I have an autoimmune problem. From my understanding, there has not been much studies with persons with autoimmune problems with COVID. Would you mind speaking on that? That's open to anyone.
I guess I could take this one as well. Sorry. So autoimmunity is a huge bag of conditions. So there's autoimmune conditions that are actually managed by multiple different specialties. So you might be seeing a rheumatologist, you might be seeing a GI physician. But what I can tell you is that each of these different groups have actually issued statements indicating that they do encourage their patients to proceed with the vaccine. yes, was it specifically studied look in every single autoimmune condition? Perhaps not, but this was not a factor that people were removed from the studies. I know there's a statement from the Canadian Rheumatology Association as well as the GI ones kind of focused on this, encouraging their patients to still proceed with the vaccine. Vaccination is not typically contraindicated in just generally in autoimmune conditions. If you have specific questions, talk to your physician and have them also give you kind of the reassurance or the information that they have about your specific condition.
Okay, thank you. And there are a couple more questions, but I think we only have time for one more. And this is a I'm going to say it's a two-part question. There has been discussion in media about business, airlines, restaurants, etc., asking for evidence of vaccination in future to gain access to these services. How do we balance choice, coercion, and potential future stigma and exclusion of those who do not get the vaccine? Oh. Unfortunately, I cannot answer that question, so I'm depending on the panel. Would you like me to repeat? All right, I will repeat. There has been discussion in media about business, for example, airlines, restaurants, asking for evidence of vaccination in future to gain access to these services. How do we balance choice, coercion, and potential future stigma and exclusion of those who do not get vaccinated?
Yeah,
by no means am I an expert, but this is a loaded question in that there is a large ethical component behind this. In terms of society as a whole requiring a passport to show that they have been vaccinated. So I think that this question is really at a level beyond this forum. And I'm not so sure or confident that this is even something that could be legislated at this point in the pandemic. So I would say, to just stay abreast of the conversation. And I think that we're a long way from even having a conversation about, the ethics and having a passport to really access service or access anything at this point. So that's just my opinion.
My quick response would just be to say that this is a balance between civil liberties and sort of freedoms and safety. Really, I think sort of safety not just of oneself, but safety at a population level. And it's going to be a balance, and there will be trade-offs if someone makes a choice and for their own personal reasons, or maybe there are even medical reasons as to why they made a decision not to get the vaccination. There will be consequences, right? And some of them will be sort of negatively reflected in terms of, and as in this case, access to go on an airplane. But those are trade-offs, and that the good out of these decisions is not on an individual level; it's on a population level. That would be my brief response.
Yeah. I was just going to say very quickly, I realize it's 1 o'clock, but just to echo that sentiment, it's important to recognize the opportunity that exists from industrial commercial partners and what we can do to leverage important resources to engage with the community, to have a better understanding of what the systemic issues are, rather than look at things from a draconian perspective and implement legislation without understanding the context of in which things occur. It's an important balance and measure that needs to occur, but I think we need to have discussions with the community and business partners at large to ensure that people are not disenfranchised and you continue this vicious cycle of systemic racism and marginalization of the population.
Okay, thank you everyone, and we are out of time. And I'm very, very pleased, excited that we've started these conversations. And I just want to say a big thank you to our panelists. And thank you for availing your time. Thank you for speaking to us about COVID-19 and the vaccine and making us more confident about the topic. Just as I would say as a PR announcement, a week from today, along again with our Black History Month, we're having a fireside chat with our president and with an esteemed guest, Dr. Notisha Massaquoi. She's a subject matter expert in areas of health equity and anti-Black racism. And this will be a virtual fireside chat. It starts at 6 p.m. So it's a fireside chat. So whatever beverage you will be consuming, make sure you are at home. It will be a fireside chat, so nothing too hot. And we look forward to seeing you next week, Wednesday. Again, thank you to everyone that signed on. Thank you to our panelists. And we will see you at our next conversation. Thank you.